All right, let's get started. Next slide. Here are the instructions for what I was telling people to do. Rename yourself with your full name, the city you're from, and if relevant, the organization you represent. And if you don't know how to rename yourself, you click on the three little dots at the top upper corner of your facial image on the screen. Look for the rename on the list presented and click on it, and then fill in the blank with the information requested. Next slide. So we are going to be collecting your questions in the chat function. Audrey Hobbs Johnson, the VP of Education, will monitor the chat and direct questions to the presenters during the Q&A session, which will follow the speakers and the roundtable. Next slide. And now I'm going to take a moment to do a land acknowledgement in the context of Elder Action Day. We are gathered virtually on this land, which has been the traditional home to many First Nations, Inuit, and Métis people. The lands on which we work, live, and play have been traditional homelands to Indigenous people from time immemorial. In trying to make sense of Canada's past, we must reflect on the truth of what has been and continues to be perpetrated on the Indigenous peoples in the name of the doctrine of discovery, and later through colonial attitudes and policy founded on this doctrine. We must acknowledge our forefathers' role in forced subjugation, forced relocation, and forced assimilation. We must recognize that colonial practices continue today and that we both knowingly and unknowingly contributed to these practices. We must do all in our power to reconcile with the First Nations, Inuit, and Métis, who were and continue to be wrongly targeted by policies designed to eliminate their culture, language, and genetics. Today, we consider all our elders, the wisdom keepers, language keepers, and life givers who have held our communities together. Today, we learn about home care for all elders and their kin, how it works or doesn't work, and what we can do to make a difference. Elders, Indigenous and colonial, may be leaders or they may have been forgotten people. We listen and share our knowledge on their behalf today as we collectively strive for deeper understanding, greater appreciation, and better relations among all people. As part of our reconciliation efforts, we need to be guided by Indigenous, Inuit, and Métis practices that hold our lands and waters as living beings to be venerated, to be used for no more than is needed, and to be stewarded with reverence so that all the lands, living things, and people can live in harmony. Overall, we must aim today and every day to listen, learn, establish meaningful relationships with our elders, engage in courageous conversations, and take action to advance our work for better home care, for better work, and for reconciliation. I'd like to introduce now Linda Sestock, the president of CFUW, to bring greetings from CFUW.
Thank you, Heather. Good afternoon and welcome. Bonjour et bienvenue. Merci pour votre participation aujourd'hui. Thank you for joining us today in observance of Elder Action Day, featuring a distinguished panel of guest speakers. The CFUW is made up of over 90 clubs and over 6,700 members throughout Canada. We take pride in awarding more than $1 million in annual scholarships and advocating for women's rights and issues that benefit our entire society. We are pleased to welcome a significant audience of members and guests today, with over 200 registrants for this webinar. I'd like to express my gratitude to CFUW Vice President of Education, Audrey Hobbs, National Vice President of Advocacy, Heather Oxman, as well as the many CFUW members who contributed to the organization of this significant event. We also appreciate the support provided by the National Office and Executive Director, Jamie Bagan. Their efforts ensure the seamless delivery of today's session. enabling us to further our understanding of aging in place and its profound implications on our lives and on those of our children and parents. Thank you very much.
Audrey?
It's my pleasure to welcome everybody today again and to just say thank you personally to the facilitation team who have put this together over the past few months. So I'm Audrey Hobbs-Johnson. I live in North Vancouver and I'm VP Education. Heather Oxman is from Lethbridge, Alberta, is the VP from Advocacy. And not really behind the scenes because they work with us to make this work for us across the country. Jamie Bagan, who is the executive director, Mabinti Toure, Camila Tap, and Elizabeth Malcolm, who are real life people who you won't see a lot of, but you need to say thank you to. Over to you.
Now the agenda for the event. I will introduce the speakers all at one time, and then we'll hear from André Picard, Sharlene Webkamigad, Liv Mendelson, Janice Keefe, and then Anthony Quinn. And we'll have a wrap-up from André. Then we'll have a roundtable, which could last up to 20 minutes, where the speakers will talk amongst themselves and compare notes as they have heard each other speak. Then after the roundtable, we'll have a Q&A from the audience where we will harvest your questions from the chat, and Audrey will share those questions with the speakers, and then the session will close. And now each speaker will present for approximately 10 minutes on an aspect of home care. So don't forget to put your questions in the Q&A box. And they will be transferred to the chat for Audrey to choose from, because I'm sure you'll have a lot of questions. So, given that, let's see what the biographies of the speakers are. Our first speaker will be André Picard, who is a Canadian journalist and author specializing in healthcare issues. He works as a reporter and a columnist for the national newspaper, The Globe and Mail. As of 2020, he runs the news organization's office in Montreal and currently lives in Vancouver, which must be kind of challenging. His book, Neglected No More: The Urgent Need to Improve the Lives of Canada's Elders in the Wake of the Pandemic, was a nominee for the 2021 Balsillie Prize for Public Policy 2021, the Sanford Fleming Medal for Excellence in Science Communication of the Royal Canadian Institute for Science. In 2023, he was inducted as a member of the Order of Canada. He's received honorary doctorates from 6 institutions: the University of Ontario Institute of Technology, the University of Manitoba, Laurentian University, Carleton University, the University of BC, and the University of Toronto. Our next speaker will be Sharlene Webkamigad, who is an Indigenous health researcher, educator, and advocate, and an assistant professor at Laurentian University. Her research focuses on Indigenous health, particularly in supporting aging Indigenous populations. She's led several research projects and has an academic background in Indigenous relations, nursing, and geriatric health. Dr. Webkamigad actively contributes to community-based research while being recognized through awards and publications for her dedication to Indigenous health and well-being. Next is Liv Mendelson, who will be speaking third. As Executive Director of the Canadian Centre for Caregiving Excellence, a program of the Azrieli Foundation, she works to strengthen the systems and communities that support caregivers and care providers across Canada. She leads this work through research, innovation, policy engagement, and co-design with people whose lived experience shapes and guides the sector. A lifelong caregiver, Liv brings her own experiences as someone with a disability and as a member of the sandwich generation to everything she does. Throughout her career, Liv has founded and led organizations that center inclusion and community, including the Wagner Green Center for Accessibility and Inclusion and the Real Abilities Toronto Film Festival. She serves on the City of Toronto Accessibility Advisory Committee and sits on the board of the Canadian Brain Health Foundation, the Kids Brain Health Foundation, and the Center for Independent Living in Toronto. Liv's work has been recognized with the City of Toronto's Equity Award and honors from the University of Toronto, Empowered Kids Ontario, Shalva Center, and the Jewish Community Center of North America. She speaks regularly about caregiving, disability inclusion, and social change, and her insights are featured in media and public forums across Canada and internationally. A senior fellow at Massey College, Liv is also an alumna of the Mandel Institute for Nonprofit Leadership and the Civic Action Leaders Program. Next, Janice Keefe, who is a professor and chair of the Department of Aging and Family Services at Mount St. Vincent University, holds the Lena Isabel Jodry Chair in Gerontology and is director of the Nova Scotia Centre on Aging. She is an adjunct professor with Dalhousie Medicine, an affiliate scientist with Nova Scotia Health, and a fellow of the Canadian Academy of Health Sciences and the Gerontological Society of America. Janice regularly contributes as an expert on national initiatives like Statistics Canada's Demography Committee and the Royal Society of Canada's reports on COVID-19 and long-term care. Janice has had, hang on, don't switch that slide so fast. Janice has had a focus on family and friend caregivers since graduate school, including developing the CARE assessment tool and evaluating national and international policies for financial support of caregivers. During her 30-plus year career, she has led several multidisciplinary tri-council and government-funded projects focused on family, friend caregivers, home care clients, and caregivers, and most recently, leading the Atlantic Canada Research Collaboration, assessing how work environment impacts the quality of work life, QWL, of staff in long-term care. And our final speaker is Anthony Quinn. Anthony is the president of the Canadian Association of Retired Persons, or likely known as CARP, Canada's largest national association advocating for older Canadians. Building on more than 4 decades of CARP's work, he leads national efforts to strengthen financial security, improve healthcare, and combat ageism, harnessing the collective voice of members, 250,000 of them, and drawing on over 17 years of experience to advance evidence-based policy change. Please welcome our speakers, and let me start by reminding you to put your questions in chat and welcoming André Picard to begin our discussion.
Great. Thank you, Heather. And welcome to all the other speakers. It's an honor to be on this call with you all. I'm going to start with a very brief overview of what is the state of home care and elder care more generally in Canada. And again, happy Elder Action Day. I'm happy to be here as an active elder to speak to you. So what is the state of home care today in Canada? Overall, I think it's fair to say it's not in great shape. There's many, many challenges, and the challenges are going to only grow over the years. There are several issues that we can touch on, and I'll just touch on a few. There's probably many, many more. First of all, there's high demand from home care because the population is growing and the population is aging, and our families are shrinking, so we need that outside help. There's limited availability of services. It really depends on where you live, the care you can get, how much money you have. It's a real mishmash, and we'll hear, again, more details on this, how things vary around the country. We have a workforce that's stretched to the limit. It's leading to burnout. It's leading to high turnover. And part of the workforce issue is that we're very dependent on foreign workers in Canada. Anybody who knows healthcare workers know we're very, very dependent on that important group of people to come into Canada and help us out. But there have been drastic changes in how we handle immigration and foreign workers in particular. So we're going to see that crunch really come in the months and years to come. Access, as I mentioned, is very variable around the country to home care. It's really a postal code lottery. If you're lucky to be in a city or a region that has good home care, you'll do okay. You could just be across the street and be in big trouble. There are high out-of-pocket costs. Home care is not necessarily covered by Medicare. Again, it's often depends on your income, but for many people, there's a really high out-of-pocket cost. Some nursing care can be covered publicly, but especially essential support services like meal preparation and cleaning often are not. So there can be a big outlay of money from families every month. We have to remember that 75 to 90% of all home care is actually provided by informal and family caregivers, and there's very little support for them. A lot of us are just thrown into this by an aging parent or grandparent, and we have to make do. Home care is also a business. It's an $8.1 billion a year business, a mishmash of nonprofits and for-profits, municipal services. There's a little bit of everything in there, but altogether, they can't keep pace with demand. There's a lot of talk about, the need to shift care to the community. Everybody wants to stay at home, age in place, but the resources are not following the talk and the rhetoric. Home care is still provided largely as an alternative to acute care, to acute hospital care. Tends to be short-term, temporary. If you want to get ongoing home care for treatment of a chronic disease, a chronic condition, it can be very difficult, but this is the way we have to go. It's the only way to keep people out of hospital and out of long-term care facilities. In the end, home care ends up being cheaper, but only if you can provide it. And even if you do have chronic care at home, which some people do, there's little continuity of care because, as I mentioned, a lot of turnover. Now, home care, of course, is just one aspect of the elder care puzzle. There's a lot that goes into this: primary care, hospital care, rehab, home care, long-term care, palliative care. All this is connected in one way or another, and every change in one part of the system has an impact on the rest. The reality is that millions of people are navigating the caregiving journey every single day, and they're doing it with very little guidance and minimal support, and that's problematic. You'll hear more about this later from Liz Mendelson. They do these wonderful annual reports, but she'll remind us about 8 million people in Canada are caregivers, about 1 in 4 adults. They contribute a lot, on average about 5.1 hours daily of care for a loved one, and they do so for a long time, about almost 5 years on average. So caregiving is essentially a full-time job for many Canadians, one that pays very badly. There's no pay at all. There's very little tax relief. And you have to do this in addition to everything else in life, your paid work, school, and your other duties like child rearing. We heard Liz introduced as a member of the sandwich generation, and many caregivers are. In 2024, the federal government budget announced a caregiving strategy. Now, that's been worked on by people in the sector. It's been put forward, but it still hasn't been given the oomph that it needs, the money it needs to make it a reality. So we'll watch for that. Reminder too that caregiving is very physically demanding for both providers, paid providers, and families. We need training. We need training of our workers. We need training of people at home. It's very difficult to do things like change a continence pad on an 80-year-old with dementia or to bathe them. And you don't just learn this stuff magically. It has to be taught. We don't give people caregiving classes the way we do for new parents, and we probably should if you're going to have a new elder to care for at home. Last thing I'll say, it's expensive. People spend about $1,000 a month on average out of pocket when they have a loved one who needs care for things like home care and otherwise. And I'd say we have to take a lot better care of our workforce. The sociologist Pat Armstrong famously said, the conditions of work are the conditions of care. And the conditions of work are very, very difficult for workers. And as a result, the care is not what it should be, through no fault of the workers, but the system failing both them and the people they care for. As baby boomers age, the volume and the complexity of care is only going to grow. We also have an epidemic of loneliness that's contributing to our lack of good health as we age. So both the informal caregivers and the paid care providers are aging too. So all these factors are coming together in kind of a perfect storm to make it a really challenging time out there. So that's my brief overview. I look forward to hearing from the other speakers who are much more informed and more educated than I am on this subject. I look forward to learning from them and giving you a brief summary in a little while. Thanks.
Thanks, Andre. And now we'll hear from Sharlene Webkamigad, who will give us the Indigenous perspective.
Can you see my screen?
We can.
All right. Ani, hello, everyone. Sharlene Webkamigad, Minwa Wabegege Kwe. I'm from the Wakwamukong unceded territory in northeastern Ontario. I'm an assistant professor at Laurentian University. I want to acknowledge all of the older adults, caregivers, healthcare providers, and elders who have really informed and shaped what I'm about to present to you. Also, my mentors and supervisory committee members in the work that I've done to learn more about home care for Indigenous communities. I became interested in holistic health at a young age and pursued a career as a nurse. I first cared for older adults at the Wakwamukong nursing home. From this experience, I became passionate about holistic health education for chronic illness prevention and management. The more I focused on older adult health, I couldn't help but notice the severe health inequities facing Indigenous populations and lack of culturally grounded healthcare delivery. I shared my frustrations on how the healthcare system does not prioritize Indigenous health while visiting with a mentor of mine, Dr. Kristen Jacklin. Dr. Jacklin encouraged me to apply for Laurentian University's Masters of Indigenous Health and Rural and Northern Health PhD programs to learn about the healthcare system. Currently, healthcare is delivered through a Western lens that differs from Indigenous ways of knowing. The domination of Western values and knowledge across all of Canadian society has notably caused health inequities in Indigenous populations, with First Nations, Métis, and Inuit populations facing higher rates of chronic diseases from the majority population. Elders, in particular, are experiencing higher rates of age-related illnesses that can cause them to become isolated socially and culturally, as they may not have the same abilities to engage in cultural activities in the same way they have done in the past. They may even be moved away from the community to be placed in an older adult home. As older adult homes are also designed under the dominant Western lens, there is little opportunity for elders to engage in cultural activities. Beyond being isolated from their community and culture, the institutionalized feel to older adult homes can cause harm, as the institutional style may be a reminder of residential schools. While I acknowledge that trauma from residential schools is felt through generations, it is especially important to keep in mind the impact of residential schools on elders. Acknowledging the impact of residential schools and wider colonial practices on Indigenous people is an important component of providing a higher quality of care through making the way we care for elders culturally safe. Cultural safety, as established by the New Zealand Maori nurse Dr. Ramsden, can be described as acknowledging and understanding how dominant Western systems have led to the current health disparities that Indigenous populations face. Culturally safe care is care that is respectful to cultural values. Cultural safety also empowers individuals to make informed decisions about their health through making health information culturally accessible. Culturally safe care for elders can look like creating a healthcare system that is culturally grounded, providing opportunities for patients to engage in cultural practices, having a translator who can inform a patient about medical procedures in their native language, and so on. There are many ways culturally safe care can be pursued, but they all begin with spending time with elders and asking what they need and want from their care. My work, for example, has focused on making healthcare delivery more culturally safe. In my research that is focused on dementia, the majority of the health information materials about dementia are not culturally safe nor culturally accessible. This is because the informational materials supply mainstream Western messaging, which differs from Indigenous ways of knowing. Dementia, in a Western perspective, is an umbrella term of medicalized conditions regarding cognitive decline like Alzheimer's disease and vascular dementia. Many Indigenous people, however, view symptoms of cognitive decline as we age part of the natural cycle of life. To make health materials about dementia culturally accessible and culturally safe, I visited with the Indigenous individuals in Swakamuck, where the three roads meet, or Greater Sudbury. From these visits, I learned that forming cross-cultural understandings about health was a critical component towards improving dementia care for Indigenous patients. The highest recommended way for cross-cultural understandings to be reached is through open communication and sharing of knowledge, which occurs through the act of visiting. Another example of how we can integrate Indigenous perspectives into the delivery of home care is to critically examine the current definitions of what home care is. These definitions are aimed to assist community members to live independently in their home and community and include services as offered by the Home and Community Care Program, among other relevant social programs with similar aims. From the lens of two Anishinaabeg older adults in a First Nation community, these definitions can also include additional key principles, such as community-level supports must be inclusive and accessible to all. They must promote visiting and connecting, promote culture, are private and confidential, offer opportunities for outings, and use many avenues for awareness. Connection is a fundamental human need, impacting our holistic health physically, mentally, emotionally, spiritually, and culturally. From my experience as an Anishinaabe nurse student and researcher, I have learned the power of visiting and connection and its impact on holistic well-being. To prevent loneliness and social isolation, visiting, as in the old ways of visiting, is when a deeper level of connection occurs. Often, components of visiting include the listening to and sharing of stories. As a research participant from a project focused on knowledge translation shared with me, visiting means to take time to really listen directly, stating, "You guys, if you want to do native ways, listen." Listening, however, can also mean listening to the need to share a moment of silence together. Being comfortable in the quiet with a loved one can also foster a deeper connection. Storytelling is an important activity for many Indigenous communities. Notably, the sharing of stories often occurs with visiting. As another researcher participant noted, "I think it's really important in my own experience is really taking the time to visit people. Yeah, and we have always been storytellers, and our parents and grandparents taught us lessons through storytelling too." Similarly, the positive benefits that connection through visiting has on holistic health makes it important to support programs that coordinate volunteers to visit elderly in the community, especially those who may be more isolated. Healthcare providers need to visit with both the Indigenous community and establish a personnel connection with individual patients. Through visiting, healthcare providers become informed on how they can improve their healthcare design and delivery to be culturally safe. Communities and healthcare providers are not the only ones who are able to positively impact the health of older adults through visiting. You can make a positive impact on the holistic health of an older adult as well as well as your own well-being through enjoying the benefits of connecting that comes with visiting. Visiting has the potential to not only improve Indigenous health through promoting cross-cultural understandings, thus cultural safety, but also has the potential to improve health for all humans regardless of culture. This is because of our shared nature of needing connection. Miigwech.
Thank you, Sharlene. That was very informative and excellent look at the power of visiting and connection. Terrific. Our next speaker is Liv Mendelson.
Hi, everyone. I'll just get the slides up. I'm
Yep.
Liv Mendelson. As mentioned, I'm the Executive Director at the Canadian Centre for Caregiving Excellence. And as Andre alluded, I come to this work as a caregiver myself. I know when my mother was caring for my grandmother, she called herself a member of the sandwich generation. I think at this point we're members of the club sandwich generation. I've been a caregiver all my life. My grandmother lived with us when I was young and cared for me. And over time, as she developed Alzheimer's, we grew to care for her. And I've cared for my mom through ovarian cancer and palliative care. I'm caring for my sister through cancer, for my dad, and caring for my children as well. And I think that experience is much more common. It actually is the experience of every Canadian family in many ways. So care identities shape how I understand this issue. For me, caregiving is personal and relational. We know care is rooted in love and duty and family and community, but love is not a policy, and family responsibility can't be the foundation of our entire care system. At the CCCE, our contention is that caregiving isn't just a private family concern, it's a public infrastructure issue. It affects aging, women's equality, affordability, workforce participation, disability inclusion, and the sustainability of our healthcare system. And CFUW has long understood that equity is not only about access to education or employment, although those are essential. It's also about whether our public systems recognize the reality of women's lives, and caregiving is one of those realities. So, about our center, for those who don't know us, we're working to make care more visible in public policy, better supported in practice, and more valued across the country. We work as a funder, convener, and sector strengthener. And we invest in promising work, bringing people together across aging, disability, and health sectors, together with community to push for public policy that reflects what people are actually living. And one of the key tenets of our work is that we look at the whole care ecosystem. So, unpaid caregivers, paid care providers, and people accessing care are deeply connected, and we need to bring that lens together. Too often, policy separates them. It talks about patients over here and workers over there, and families somewhere in the background, if at all. But we know that's not how real life works, and it's essential to look at all three together. When caregivers are unsupported, health outcomes for care recipients plummet. When care providers are underpaid or unsafe, families feel it. And when systems are hard to access, everybody absorbs the consequences. So our work is about strengthening the whole system of care. You can go to the next slide for me. Thanks. So most of us will give care, need care, or both. But our systems are still designed as though care can be absorbed quietly and endlessly by families, friends, neighbors, and underpaid workers. And that fiction is costing us because unsupported care always shows up somewhere else. It shows up in emergency rooms, in alternative level of care beds, in delayed discharge, in burnout, in poverty, and in workforce exits. Next slide, please. The data I'm going to share with you today comes from our Caring in Canada report, which is launching May 6th. So you're getting some very fresh numbers. This research helps make visible what caregivers and care providers have been telling us for years. And notably, most caregivers don't identify as a caregiver. Like me, they would say, I'm a daughter, I'm a spouse, I'm a granddaughter. We don't identify as caregivers often until we hit barriers or find ourselves in crisis. So being able to gather this data is really important. Next slide, please. Thank you. So as André said, 1 in 4 Canadians are caregivers, and that's half of all Canadian women are caregivers. Caregivers are providing an average of 5.3 hours of unpaid care per day, which is essentially a second full-time job every week. And they've been doing this on average for nearly 5 years. The impacts are significant. 41% of caregivers face financial hardship. More than 1 in 5 spend at least $1,000 a month on care-related expenses. 77% experience negative impacts on their physical, mental, or financial health. And 61% of caregivers and 54% of care providers don't feel supported by their government. These numbers tell us that caregivers aren't failing to cope. Care providers aren't failing to care. They're operating in systems that are asking too much and offering too little. Next slide, please. And caregiving is a seniors issue. It's not only a seniors issue, but it's absolutely a seniors issue. More than 1 in 5 caregivers is over 65. Older adults are not only navigating their own aging, health, housing, income, and mobility needs, they're also caring for spouses, siblings, friends, adult children, chosen family, neighbors, and other loved ones. We often think in policy terms about older adults as recipients of care, but so many older adults are also providing care, and many are doing it with very little recognition or support. Older adults are actually the group least likely to have access support. 82% of caregivers over 65 say they haven't accessed support for caregivers. Support systems are not reaching many of the people who may need them the most. And more than a third of caregivers over 65 are spending between $200 and $1,000 a month on care needs for the person they're caring for. For people on fixed incomes, that's not a minor expense. That's groceries, medication, rent, transportation, retirement security. That's why caregiving policy is also seniors policy, affordability policy, and income security policy. Next slide, please. According to our good friends at the National Institute on Aging, 93% of Canadians say they want to age in place. And there is no aging in place without caregivers. For caregivers, affordable home care is a top priority. 83% said it would be helpful to them. And 1 in 10 caregivers took on their care role because there was no access to affordable care support options. Amongst caregivers who tried to access care services, 64% reported difficulty in finding affordable services in their community. And that really speaks to what André was talking about in terms of postal code equity. It really depending on where you live, what's available to you, and within that, what's affordable. If we're serious about aging and with dignity, we have to be serious about home care, respite, and caregiver support. Next slide, please. We can't talk about caregiving without talking about paid care providers. If we don't support care providers, caregivers are left with fewer options. And if caregivers are unsupported, care providers are asked to absorb more strain in already stretched system. When both are unsupported, care recipients, as I've said already, suffer. So the data here is really concerning. 25% of care providers feel unsafe at work, 37% feel unsupported at work, and 73% have considered changing careers in the last year. When we already have a real workforce shortage amongst frontline personal support workers, home health aides, etc., that's actually a very troubling number. It's not just a workforce issue, it's a care infrastructure issue. Care work requires skill, judgment, relationship building, cultural humility, communication, physical skill, emotional intelligence, and complex problem solving. These aren't low-value skills, they're essential skills, and we can't build a strong care system on unstable work. Next slide, please. And just to bring in a couple of voices from the survey, we surveyed 3,000 caregivers and care providers. The cost of hiring home support and care homes is unaffordable, so people are trying to do it on their own. which is causing them to have medical issues. The government needs to lower the cost of caring for seniors. And on the care provider side, most workers are doing 2 or 3 jobs just to meet basic needs, not because they're living beyond their means, but because they can't afford the essentials. You want to bring out the best in people, but then you go home to bills you can't pay. Next slide, please. So this is where the conversation has to move from recognition to action. Recognition is great. Awareness raising is great. But caregivers and care providers don't need another round of applause without policy behind it. Care cuts across health, income security, labor, immigration, disability, aging, housing, and community services, and we need a coordinated response. At the CCCE, our national caregiving strategy, developed with thousands of caregivers and policymakers across Canada and endorsed by more than 85 health and social care organizations, lays out a practical roadmap. And I'll take you quickly through it. Next slide, please. One of the core pillars of the strategy is, of course, improving supports for caregivers. Caregivers need supports that acknowledge the high costs. That includes for us making the Canadian caregiver credit refundable. It includes a caregiver allowance to acknowledge the costs like medication, nutritional supplements, incontinence supplies, services, and so many other things that people are paying for out of pocket. One caregiver told me that they spent almost $1,000 on hospital parking in 1 month recently. These aren't costs that the average family can just absorb. We are also calling for more funding for respite and home care, of course. Reliable, predictable respite care is what allows caregivers to keep going. It actually is the foundation of the resilience that we keep expecting people to hold. And we're calling for public care insurance and CPP provisions for caregivers who've had to step out of the workforce or reduce their hours. So they've had years in their career, in their long career, they've had some periods of low earnings. They get penalized in retirement for that. We want to support people caring for their loved ones, not to penalize them. Next slide, please. The next one is about care recipients. Caregivers always tell us, the best way to support me is to support the person I'm caring for so that they're more stable and it's easier. So we've had a recent win in the spring economic update, making some of these many eligibilities and forms a little easier to access in the disability space. We'd like to see more of that and the same in the elder care space. Next slide, please. On the care provider sector, we're calling for a $25 minimum wage for care providers across Canada. The government put this in place during COVID. We'd like to see it across the care sector in disability care, elder care, and beyond. People can't stay in care work if the wages are too low, the conditions are unsafe, and the pathways are precarious. And there are a number of other ways to do that we've built into the strategy. But really, it's about making sure that we have a sustainable care workforce that's not built through precarity, but through decent work. And that we look at, as André alluded to, our migrant care worker population and making sure that they're stabilized. Next slide, please. And really, we're calling for the government in the areas that are under government control to show leadership, our federal government, to establish, they have committed, this current government committed to establishing a national caregiving strategy and creating an advisory council, and a table is forming later this spring. So that is happening. And a number of other ways to show federal leadership and to show that the federal government is treating care as foundational to our future because caregiving touches every Canadian family. So I'll stop there. I just want to thank our Caregivers Advocacy Network, our Indigenous Care Collective, and the thousands of caregivers who shared their experience that informed both our strategy and our study.
Thanks, Liv. That was an extraordinary walk through data that was very impressive and depressing, really.
It
It's
can
okay.
be depressing, but the hope is in the fact that we really are building a national movement, and there's a policy response, and we've had response from government at both the federal and provincial level. So I'm an eternal optimist.
Good.
Andre may come in as as the sager fellow who is maybe less optimist, but I think there's actually a lot of hope. We can't we can't deal with this until we've named it. And so that's the work that
Yep.
we're doing.
It's good to be naming it. So our next speaker is Janice Keefe.
Hi, everyone. Thank you for the invitation. I'm pleased to be here. I'm hopefully sharing my slides now. Is that correct? Great. Wonderful. Yeah, it's really great to be here to represent some of the work that we're doing at the Nova Scotia Centre on Aging. We've been looking at home care for many, many years, and also some of the financial compensation for family friend caregivers. So it's a pleasure to be here to talk a little bit about our work, and also about situating home care in the context of aging in place and aging, the continuum of care. So just wanted to locate it. I mean, I think we all want to live in our own home. We talk about aging in place, or the notion of aging in the right place. For some people, it's about downsizing. For others, it's about staying where they have lived their lives. And so just to say that it is within that whole context of independent living, and then possibly prevention, wellness, perhaps using some resources for community care. And then I'm going to talk a little bit about some of the provincial programs in home care. So where, first of all, can we go for support? And so Liv talked a little bit about the taxation. We definitely have some federal taxes. We also have supports for family and friend caregivers, as mentioned. All of our provincial and territorial governments have a home care program that is provide some subsidy, but it may be very limited depending on where you live, as Andre has pointed out. Most of those also have respite programs. We also have nursing homes with respite. Some have caregiver benefits, and so on. There's a whole host of voluntary organizations that are out. They're not-for-profits that are providing a lot of care. Some of them are strictly run by and for older people, for volunteers. We're fortunate in my province in Nova Scotia to have a provincial caregivers group, as well as we're very fortunate to have Liz's group as well. And then there's the whole private sector. And I think that's a really important piece, because oftentimes the private sector is very much unregulated in terms of who works for them, again, depending on which province that you're in. All of the provincial home care programs or territorial home care programs have an assessment in order to be able to figure out what kinds of needs that individuals have in their program. So when we talk about community care, we need to talk about home care, whether or not it's publicly funded or privately funded individually. We talk about community-based services. We talk about volunteers. And of course, as Liv was speaking about, the family friend caregivers who do a lot of the work that is needed in this space. So when we talk about public home care, typically we're mostly, almost all have some nursing and personal care. In some provinces, it means that people are not, you have to be requiring personal care in order to receive home support services. In other provinces, that's not the case. all of the provinces and territories have assessment and case management, respite, sometimes respite include in day respite. It might be adult day programs, or it could be in a long-term care facility. Home first programs can happen to help people stay out of hospital. Often we call that acute care substitution. And some provinces also have OT, occupational therapy, physiotherapy, or nutritional supports. When we talk about community-based care, we're talking about a whole other broader term than actual home care, which can include everything from snow shoveling, friendly visiting, transportation, meals on wheels. They're really the fabric that keeps everyone in that community. You can't just live out your life and not necessarily have these supports. And I think we learned during COVID, for instance, that actually, hey, you can get your groceries delivered, and it's increasingly being used by some of the members of our community that have mobility issues. One of the really important factors about home care and how we are different across the provinces is two areas: who funds it and who delivers it. So I'll give you an example. We do work comparing Manitoba with Nova Scotia. In Manitoba, the Manitoba Home Care Program funds the home care program, but they also deliver it. So the people that are providing the care are actually employees of the health authority. Similarly, in Prince Edward Island, the government has the home care program. The workers are government workers, agency of home PEI health agency workers. In Nova Scotia, another example, we have the public program, and but the delivery is actually for mostly not for profit, but there are some for profit agencies involved in the delivery of that care that are contracted on a regional basis. And so cost is another thing that can affect. In Nova Scotia, we have a sliding scale cost, so it depends on your income. As Andre had said, how much you pay. In Manitoba and Prince Edward Island, there is a no-cost fee. So if you need it, you can get access to the services, although the other challenge is maybe the wait list. So here's some recurring type of themes in home care that I just wanted to highlight that may have been mentioned previously, but the Canadian Health Care Act it mentions home care as well as long-term care, but it's not an insured service. So there isn't a guarantee that the province, because it is under provincial jurisdiction, unless we're talking about veterans or Indigenous peoples, there's not a guarantee that cost will be paid by government. There's often a fee related particularly to the home support or personal care aspect of it. Often the nursing is covered, but the personal care aspect is not, or it's a sliding scale type of situation. So the funding, as I mentioned, it varies depending on where you live. And there are no standards for coverage or service providers. So there's a lot of vulnerability within the sector itself to that cyclical funding and political changes. So it depends who's in government and how much emphasis they're putting on the care aspect. Home care aspect. So we have a mixture of public-private providers. And I would say, for instance, in our province, if you're within the public system, the people delivering the care, we call them continuing care assistants. They're called personal care workers. They're called all kinds of different, every province has a different name for them. But what's important, I think, is in certain provinces, the standard of the education to be in those delivering home care is consistent and is regulated. And so, so there's a requirement that they have a certain level of training and training with dementia care and so on. that varies significantly in the private sector. So you can hire someone privately to provide care, but there's no guarantee that they have the same level of requirement training or education. And then all of them are accessed through that single entry or assessment in the public home care programs. In the private, is what you want, is what you get. So it's quite a bit different. And I finally just wanted to locate home care in this larger context of aging in place and what I would consider, age-friendly communities. So this is a whole, if you think about it, older people are highly diverse. The needs and the preferences that they have are shaped by social, cultural, and geographic contexts. So one of the most common elements, though, is that Canadians, regardless of age, income, or capacity, they want to remain in their own homes or in their communities as they age. So that's what's really important to people. And I think what we need to consider is, are those communities age friendly? Do they have transportation? Do they have support services? How do they treat older people in terms of respect and social inclusion? And so thinking about home care and these different programs and policies, I think needs to be in this broader context of aging in place. So I'll stop there, I think. If you have any more information or interest, please feel free to connect with me. And also, I'll just point out, we do have, if you go homecarepathways.ca, we have a CIHR funded research in this area, and we've taken many of our, I think we have 10 publications and we've put them in like 2 pages so they're accessible to the broader public if you're interested. You can also read the full paper. Thanks.
Thanks, Janice. That was interesting. Age-friendly communities is an initiative of the United Nations, and it's often applied in various towns. I know Yorkton, Saskatchewan is an age-friendly community, and various other communities across the country are working
we were
on...
involved in the age-friendly, actually it was the WHO did this age-friendly cities. And so Canada actually took on to do age-friendly rural and remote communities. So our center looked after the Atlantic Canada. So I think Canada is actually a leader in this age-friendly area. So yeah, it's a really, I'm sorry I interrupted you, but I just wanted to give a plug for PHAC in the day, the Public Health Agency of Canada, who actually took on that, hey, age-friendly is not just about big cities, it's also about all communities.
Right. Thanks. Just a reminder before we move to our next speaker, and that is to put your questions in the chat so that we can harvest them at the end of the roundtable. And our next speaker is the president of CARP, Anthony Quinn.
Thanks very much, Heather. Delighted to be here with you this afternoon, and delighted that CARP is now in partnership with Canadian Federation of University Women to create awareness of both our organizations. CARP is a national, not-for-profit, nonpartisan advocacy group, lots of members across the country, and we hope to be the pointy stick in a lot of these needs that are discussed in this presentation today. What I want to talk about regarding home care is that home care really is, and investments in home care are the only solution to the pressures that are facing our healthcare system, our broader healthcare system, with the retirement of baby boomers. So what we have is a capacity problem. We can't build enough hospitals, long-term care beds, or the healthcare workforce fast enough to absorb the demographic pressures that are already underway. And home care is the pressure valve for those hospitals, for the long-term care homes, and for caregivers and family finances. So the question is not whether we support home care or we want to age in place, it's whether that whether we can, as a nation, finally treat home care as a part of our core healthcare infrastructure. Go to the next slide, please. So Canada, and this is a new number to me. I was still talking about 7 point something million, but we now have over 8.1 million seniors, and that's already close to 1 in 5. By 2030, in the late 2030s, that will rise to roughly 1 in 4 Canadians. The oldest baby boomer turns 80 this year, and the peak wave of baby boomers arrives in the year 2037. So if you were born in 1957, you had the most peers of any generation in history up until 2007, when there was a bit of a mini baby boom. So as chronic disease becomes more common, recoveries take longer, mobility declines, falls become more consequential, and dementia requires more sustained care and supervision. We are on the precipice of a healthcare crisis. 73% of seniors live with at least one chronic condition, and about 1 in 3 older adults has a fall each year. Dementia is estimated at more than 770,000 Canadians today and is expected to approach 1 million by 2030. None of this is a surprise. The only surprise would be failing to plan for it. And one thing I want to point out to those later baby boomers, that if you were growing up in Canada in the late 50s and early 60s, particularly if you were in the suburbs or near a larger city, which blossomed because of that baby boom, you might have been born in a new hospital or attended a newly built elementary school or played hockey in a new municipal recreation center or swam in a newly built pool. All of that infrastructure was built to accommodate that massive wave of children. And that baby boom accompanied a building boom. The suburbs, the infrastructure, the services, they were all created for baby boomers. However, the policymakers stopped when you graduated high school or college or university, and they didn't plan for building the next inevitable wave. That's caring for you in your retirement and meeting the healthcare and housing needs of seniors. Next slide, please. So we're looking at the long-term care numbers, and the math just doesn't work. Canada has roughly 200,000 long-term care beds. Estimated demand is closer to 263,000. By 2035, projected to be in need of another 199,000 new beds. The capital costs are enormous, about $64 billion in construction, and operating costs for those new beds through the next decade are estimated to be over $130 billion. So money is one constraint. Then you need land, construction capacity, regulation, staffing, management, and time. So long-term care is necessary for people with complex needs, and that number will continue to grow just as the baby boomers grow. Excuse me. But if long-term care becomes the default solution for where we age, the system is guaranteed to fail. What we need is to reserve long-term care for the most complex cases and build serious care capacity at home. Next slide, please. Currently, when there's no home care provided or available, when there's no home care available and no long-term care bed available, hospitals become the system overflow. And that's a bad policy, and that's expensive policy. There's an average of 25 ALC care days for older patients awaiting residential care or being moved out of the hospital to another destination. And the differences in price are staggering as well. $949 a day for an alternate level of care patient in a hospital bed compared to $142 a day in a long-term care bed. So we have a long-term care system that can't meet the need and the demand, and we have a hospital system that is being engorged with patients who no longer need acute care in the hospital. That's costing our system money. So this isn't an appropriate use of our healthcare dollars. A day in a hospital bed is not available for the next person waiting down in the emergency room trying to get upstairs, or who needs surgery or a diagnostic procedure. Home care is not just about comfort, it's about protecting our hospital capacity. And just anecdotally, one of the other concerns that I've been voicing at CARP, and we're starting to see it now, I think, is the intergenerational divide that will come with the increasing demand for hospital and ER care. The example I use is a mother taking her young toddler to the emergency room with a raging fever, and that mother will find herself today and more likely in the future in the triage lineup with dozens and dozens and dozens of seniors, maybe more than dozens and dozens. And she'll be angry at having to wait in line for her daughter because of all those seniors hogging the healthcare resources. I think it's certain to happen if we don't solve the issue today. And that could lead to some serious age discrimination problems in the healthcare system unless we work to protect those, to fight against those bottlenecks in the ER. Next slide, please. So the demand for home-based aging is logical, is understandable, and we know it's the preference for the vast majority of seniors. The National Institute on Aging, who were referenced earlier, say about 81% want to remain in their home or live in a smaller home in their community for as long as they can. CARP members tell us that it's about 97% of them who intend to age in place. But according to those NIA numbers, only 51% who needed home care said they could obtain it all or most of the time. So half of them aren't getting the care that they want or need. And cost and wait times are the two biggest barriers. So that's a gap we need to close. Aging at home is simply not a personal choice. It requires it being accessible, reliable, and that there be the caregivers, transportation, and support so that aging in place becomes a reality rather than a slogan. Next slide, please. We polled our members recently, and our members aren't confused about their priorities. In our omnibus poll, just closed a couple of weeks ago, 95% agreed that aging at home, including incentives, improved home care opportunities, and caregiver supports, should be a priority that we advocate for. 91% supported wellness, prevention, healthy aging, including fall prevention. And that means home care as the investment that Canada's policymakers have to make in order to prevent the downstream pressures on hospitals, ERs, long-term care beds. Next slide, please. Another personal point of view, we're experiencing the fallout of what has been a cultural shift. And I think we're really still in the experimental stage in Western society. For much of history, care happened in or near the family home. Some cultural and ethnic communities still maintain stronger multi-generational arrangements, and that can be a strength. But in the 20th century and now, younger people have been encouraged to leave home for opportunity to another city, another province, another country. Parents have often encouraged that. The result is that the adult child who may have provided daily care to an earlier generation may not be physically available. The CARP poll just said that 1/3 of our members live alone and more than half live with their spouse or partner only, and therefore they rely on neighbors, friends, or adult children to manage their care from a distance. So that's not a stable health system strategy. And with ongoing declining fertility rates, the pressure will only increase. Next slide, please. And we talked a bit about the private market when it comes to living in your own community. Andre mentioned the private market and the prices in the Greater Toronto area. A retirement home, a retirement residence is $5,000 to $6,000 per month. That's not unusual. Before adding in private care options, you're looking at $8,000 to $10,000 per month as care needs increase. So that is not a realistic default for most households. And CARP has learned from our members that 31% had already delayed or foregone home maintenance because of financial constraints. So while we are telling our members to prepare and invest in being able to age in place, they're already cutting down on the care that they need because of financial pressures. So in reality, planning to age in place is more difficult than it seems naturally. Slide 9, please. Next slide. So for ensuring that we can age in place, we have to prepare and not be stuck into critical or crisis modes with acute changes in our health. We have to have plans in place so that if we have a fall and are in the hospital and are discharged, that we have already prepared to have living accommodations and cleaning accommodations on our main floor and have access to our homes. Otherwise, if you're a homeowner, you may be forced to sell your home in a hurried state. You may be forced to go into respite care at a high expense, and these costs can be mitigated by planning ahead of time. Next slide, please. I see my time is going quickly. CARP has a call to action, and that is a homes first model. The only way that Canada can meet the demands of the baby boomer wave that is currently here and will continue to grow is to invest in home care first. We have to invest in home care services that will prevent the inevitable move into the healthcare system, institutions, including ERs, acute care beds, and long-term care homes, by investing in that preventative care, fall prevention, diabetes care, and the many other ways that we can help Canadians reside where they want to. And it's the only possible way to meet the impending demand. And the next slide, please. That's it. So I just want to say that CARP, as an association, we have 3 pillars. It's advocacy, benefits, and community, A, B, and C. We ask our members and seniors in Canada to hold the government accountable to meet these most pressing healthcare demands for seniors. And the only way we can do that is to hold them accountable at the ballot box. So whether you're voting red, green, orange, blue, purple, we ask that voters talk to their elected representatives or those who want to elect them and say, you don't get my vote this time until you promise to meet these demands. And if they don't meet the demands, then we have to take political action to make changes. And the voice of older Canadians as voters at the ballot box is very important. And it's the power that we have, and maybe the only power we have to make those changes. Thank you very much.
Thanks, Anthony. Well, Andre, you have a tremendous challenge to sum up these speakers in 5 minutes. But before I open the floor to you, I want to remind people once again to put your questions for the speakers in the chat, and we'll be harvesting those questions and be prepared for the post roundtable Q&A. So take it away, Andre.
Thanks, Heather. I noticed there's some really good questions. So not only am I going to summarize in 5 minutes, I'm going to do it in 2 minutes so we can have more time.
Okay.
So let me go over briefly. Sharlene underscored, the health inequities in First Nations, Inuit, Métis communities, the lack of culturally safe and appropriate care, especially for dementia, some really large issues. Liz talked about, families are doing an enormous amount of caregiving, but they can't do it alone. We really need a policy response. The center has really given them a blueprint to act on, and all they have to do now is act. So that's an important one. Janice talked about, where can older people go for support? It can be difficult because it's different everywhere. It's a lot of challenges, a lot of groups, but a lot of the communities coming together and giving care, but it can be more organized would be my summary. And everybody wants to age at home, so we have to have age-friendly communities. Can't just magically do it. Have to work on it. And finally, Anthony had some sobering numbers about the state of elder care and the needs of elders, and a really important call to action that, if we want to age in place, we have to prepare for it. If we want to not have this intergenerational divide with elders really having a disproportionate burden on the healthcare system, again, we have to plan for that and we have to talk about it. So there's my 2-minute summary, and look forward to the questions.
I invite the speakers to now talk amongst themselves. Do you have any observations across the table that you want to share? Go ahead, Anthony.
I just wanted to thank Liv for laying out the types of things that the system has to invest in order to meet the current demand and what will be a really crisis level future demand. That type of litany of things that will be in place make financial sense from CARP's point of view, from my point of view, because investing early will save money later on in the system. And I think, Liv, maybe I'll ask you just to see how can the government, how can we listeners today get the government to pay attention to those needs?
Thanks, Anthony. I think and your members have been so active as they always are, right? Advocacy shock troops in some ways. I think we have a problem of sort of stasis that we have to shake ourselves out of. We know what the solutions are. The studies have been done. The policies have been laid out. The policies have been costed. And we've had commitment. We have a national caucus with members from MPs from all parties who've endorsed the strategy. We had commitment in the last election from both the Conservative and Liberal parties, election platforms, and we get all the right signals. But you may have noticed that our government has been very busy putting out fires in foreign policy. And that has taken up a lot of bandwidth. And so we're hoping that as the government begins to turn again to our crumbling healthcare system and some of the domestic crises that we have, that we can nudge them to bring this and also the policies that you're talking about, particularly investment in home care and in upstream issues that will save our system so much money. So they can get involved with you, of course. They can get involved with us. We have a 35,000 strong advocacy group. So if you want to get involved, info@canadiancaregiving.org will sign you right up. And we have, members talking to their MPs, MPPs, MLAs every single week. So it's a very active group. And we also, with our national caucus, we have whatever political party, whatever stripe you are, you have some advocates who've already put their hands up to say, I want to hear from you. So we can also help set up meetings directly with those MPs who really do want to be hearing from you all.
Anybody else have comments on activism and advocacy? Janice?
Sure. I guess I was thinking about Liv's comment around in the strategy around supporting caregivers financially. And if I understood it correctly, you were talking about people family and friends who provide payment. And I know that Nova Scotia is one of the first provinces to have a caregiver benefit, but some of the more recent ones, I know PEI well, because they have a sliding scale, and I mean, Nova Scotia's been $400 a month for eons, and PEI goes from, I think it's 250 to 1,500 depending on what your income is. I was curious about how you, and I thought it might be helpful to have examples for the advocacy work that is ongoing. And I wondered, the 650 that you mentioned, where did that come from? How did that
Yeah.
come
I
about?
mean, I think Canada's learning from the Maritimes. The Maritimes is leading the way here in these benefits, and we see New Brunswick coming online as well with
Yes.
their new premier. That
Yep.
benefit is coming forward. The numbers vary from region to region, and in terms of the costing, we looked at the average spend out of pocket, and we worked with our provincial caregiving affiliates. So there are 7 right now, provincial caregiving organizations, but also with policymakers, because we need our ask to be measured and realistic at the same time. And we took a look at lots of other jurisdictions like the UK, South Korea, Japan, Australia, many, many, many countries. We're not talking Scandinavia like the dream of social benefits. We're talking many other sort of peer countries who have a carer's allowance or an income support for care. Even our friends in the US have a system through Medicare where families can be paid to be the caregiver. So if you're dropping out of the workforce or reducing your hours, and instead of hiring a personal support worker, you can get trained to do that work. It's not for everybody. Not everybody wants to do that. But if you do, you can be paid to be a caregiver for your own family member. And we know from our friends at the SEIU union, who surveyed their PSWs, 70% of their personal support workers are going home after their shift and caring for a loved one. So, we are triangulating here. We have workers being paid to care for somebody else when they could be using those skills to care for their own family member at probably less costs and a much more stable experience for their loved one, especially if that loved one has dementia and really needs that continuity and consistency. So we've made a big, messy, slow to move system that really isn't working well for most people right now.
Yeah. Double duty caregivers.
Exactly.
Yeah.
Yeah.
I wanted to ask Sharlene what we could learn from the Indigenous caregiving model and the connection of the elders to the younger generations that maybe we've lost in Western society with the technological progress and the distances that North American society has.
Thanks for asking, Anthony, because Heather and I had this discussion in planning this event. We were talking a little bit about the shift in society towards working and people moving away to get to go to university, get post-secondary education, but then not coming back home to their First Nations or Indigenous communities to get integrated back into the community there. I think what I would like to share most is that, the importance of having elders stay in community is really it's really high, because it'll help to transfer language and belief systems and culture and like just the continuity of that, the thread, the fabric of the community stays when an older adult is able to stay home but are supported there. But because caregiving is provided by mainly those who are working, they have families, they have an older adult who they might need to extend some like responsibility to. People get burnt out, and like those who are informally caregiving for a family member, we consider that as like a responsibility to care for our elders. And if we can actually help to inform policy or program development, like age-friendly communities. I've read a lot about that, and when I was reading it, I was wondering like where were the Indigenous voices in this development of this type of framework. So I attempted to try to get some input from community members using community level supports, and those 7 key principles that they added were some of them are repetitive with the age-friendly community framework, those 8 pillars. Some of them actually overlap, but I think what really stands out here is the connection to culture and language is really important, not just for Indigenous communities, but I think for all communities,
Yeah.
Yeah.
for people to maintain in their
I
location.
wanted to follow on that. We had an intergenerational digital literacy program, and we brought 15-year-old high schoolers together with seniors, and they were sort of teaching each other. But I learned that most of the teenagers in that small sample size didn't know any older people. Their grandparents didn't live in the community. They rarely saw them. All of their teachers were retiring at age 50-ish. So they didn't know or interact in any part of their lives with an older person. And that was really eye-opening to me. So how can we expect them to connect and care and understand if they don't even know an older person?
Yeah.
And where were these like youth where you were connecting
They
with?
were in North Toronto, but many were immigrants, like relatively new immigrants to Canada, or they're early first generation immigrants, and others just had moved from different parts of the country to this confluence of Canadians. So they really didn't see any older people. I think maybe the oldest person they dealt with was their bus driver, their school bus driver.
Well, I think this shows the importance of those community support services, like the volunteer specific programs that can be developed. But right now there's like not a lot of space for those type of volunteer home, like supports for older adults, for organizations to take on that work and coordinate volunteers. This is where youth can actually get involved in that type of connection with older adults in their communities. They don't have to be family, but neighbors, really. Like all they have to do is look within a little 1 kilometer radius of their house and they'll find a lot, but people aren't connected individually and personally as much as we used to be, which is where I was pointing to. And like going back to the traditional ways of visiting, what we used to do is like, visit with each other on the porch, have a tea, reach out to a community member who's down the road just to see if there was anything they needed while you're heading out to the grocery store. These are just basic human things that we can all do.
I think our built environment and our race to build more giant congregate long-term care isn't serving us here. Like when there's no front porch and when we're segregated by age, Anthony, what you were talking about the generations pulling apart, and someone mentioned in the comments about how we used to institutionalize people with disabilities, and we've learned that actually integrating is the way to go for so many reasons. We're segregating people by age and by cognitive disability in these giant long-term care facilities where unless someone has a direct relative, they're likely not to interact with an older person. Where it stigmatizes dementia. If you don't see people in your community with dementia and you don't learn about dementia, then it's scary. And it's, I think we're not serving ourselves well in this race to build more and more long-term care beds, which are not homes, right? No one refers to them as, places of home. They're just beds. And I think, Sharlene, what you're saying, am I saying it right? Sharlene? Yes. Sorry. Is absolutely right. Like, how do you break down social isolation and have those practices of visiting when someone is segregated in a private long-term care building? Like, how
And
would I'm thinking like, go ahead.
Oh, I was just going to say, I think we talk about this a lot in our program because we teach aging and have students that come in that don't have that experience. They think it's a bird course. And so we're trying to actually, there's this fear factor, I think. And I think that's important because when people aren't interacting or don't have that connection, they don't know what to do. They don't, I think what you're saying, Sharlene, is it's a lesson that we can all take from, and be able to integrate even within that long-term care. So I take my intro class to the long-term care assisted living place up the hill so that they can interact with the residents, and the residents love it. That there's young people that are actually, they want to know, why are you taking a course in aging? Like,
Yeah.
And
it's
we should
important.
be, if we're going to build long-term care, which is going to be one of the solutions, right? It just is. We should be integrating it with daycares and schools, and we should be building long-term care buildings that aren't going to become husks after this wave of demographics, right? We
Yeah.
should be building buildings that can be converted to community health sites or community centers or libraries, but we're building these very, for lack of a better word, shoddy buildings. We're throwing them up quickly, and they're going to be very hard to convert to another use.
Yeah, go ahead,
Coming
Sharlene.
from like a northern and rural type of area, like there's not even enough long-term care beds or facilities to even respond to the need of those who are in our region here. Like Manitoulin Island, where I'm from, has 3 long-term care facilities, and there's like over maybe about 15 communities there, about 7 First Nations communities and about 7 to 8 municipalities, and there's 1 First Nation long-term care facility there. There's not a lot of long-term care facilities in any First Nations communities across Canada. In Ontario alone, I think there might be 5, and we have like over 600 First Nations communities across Canada. So what you guys are speaking is like, you have assisted living facilities up the road or within your area, within your cities, but those who are coming from Northern and First Nations community, we still don't even have access to that. So people are being sent away for those type of support services.
Yeah. Yeah, it's true. I mean, in past Elder Action Days, we've talked about naturally occurring retirement communities. We've talked about Eden alternatives, where, as Liv mentioned, a daycare facility in Saskatoon is combined with a long-term care facility, and it works like magic. It's wonderful, and they grow gardens, and they have animals, and it's a wonderful thing.
That would be
But
the dream.
I know it would be a wonderful thing. But time is passing, and it's time perhaps to get Audrey to harvest some questions. And let's see what the answers could be. So, Audrey, are you there? Just unmute yourself there, Audrey.
Yes, there I am. There I am. Okay.
Okay.
Several themes have come up. One theme is how do we provide programs, provide education, and obviously, since I'm the education chair, I'm really interested in education for seniors to do the planning, because if seniors are to be advocates for their own life as they age, there needs to be some planning in place. And there are several questions around how do we provide for our younger seniors, how they plan for aging in place or aging at home or aging in their community. Because often, all of a sudden, a senior realizes they've had a fall or something's happened, and they are in hospital and they haven't planned for what's going to happen. So I think, how do we provide education for seniors so that there's adequate planning in place?
Great question. I think one of the things I just would say, we've done some work with Caregivers Nova Scotia on kind of planning what is out there for people around education and support. And one thing I would say is oftentimes people, I mean, I think there's the broader plan of where you want to live. Do you want to change where you're living and that kind of thing? But there's also information that is tailored to the experience that you're having. Like you mentioned, a fall. I'm thinking of sometimes when people get a diagnosis of dementia, they get all of this information, but actually they don't need that information right then. What they need is like little bits of information and information that's tailored to the experience. So I know Anthony wants to say something, but I think there's not a one size fits all. That's all I would like to say.
Thank you.
Go ahead, Anthony.
I just wanted to add that there is some real personal responsibility that Canadians have to take on when it comes to this planning. There is a real chance that the system that you expect will be there for you won't meet those needs, whether it's getting a long-term care bed as soon as you need it instead of having to wait a year for a bed, or that there will be the services that keep you living in a status of dignity that you have come to expect. So I think there is a responsibility to the individual to plan ahead. But as a group, the baby boomers have been responsible for such important cultural changes that I think how we age will be the last thing that they change before the boomers move on. They changed the role of women, they changed race relations, they changed music, they changed so many things as they have gone through that I think the last thing that they're looking at is, oh my God, this system isn't what we thought it was, and we're going to fix it before we're gone.
That's encouraging because one of the pieces you said was around now we don't want to set up this antagonistic piece between generations. We want generations to realize they need to work together. So thank you. I'm looking at.
Can I shout out one resource for folks?
Absolutely.
Okay.
Thank you.
So for people looking for something practical, and Janice is right, the provincial caregiving organizations have some planning tools, and I'm sure CARP has some great stuff as well. McMaster University has a course called Caregiving Essentials. It's a free continuing education course. And whether you've found yourself with a new stroke or dementia diagnosis in your family, or you're just trying to plan ahead, it's a great program that I think we all probably should be taking for preparation.
Great recommendation. And just for people's information, Liv has provided a couple of sheets of information which will be available to all the registrants on this program.
Another theme that I'm picking up through the questions is the actual role of post-secondary institutions and how we are all connecting with them. Because post-secondary education shut down some programs right away because they're not funded. And they're smaller programs, they're not sometimes not degree programs, and it cuts down on building the skills of people we need to work in community, supporting at home, and so on. How do we, as groups, advocate to the government, to whoever, so that post-secondary institutions are more involved? Because who is it that says, and the conditions of work are the conditions of care, and
that's Pat Armstrong.
Pat Armstrong, exactly.
We all know.
So
are you asking about how post-secondary need to have more, their curriculum have more older focus on older people and older geriatrics as well as social supports? I'm not quite understanding the question. I know yeah.
Let me read one of the questions.
Okay, sorry.
That's all right. Because there's several, and this is one. The needs here also connect to higher education's issues, especially college polytechnic institutions.
Okay.
This secondary programming through reduced funds and reduced number of students, especially in programs of continuing care, they have been cut. Have there been any lobby efforts in the post-secondary training increase? So that's one of the questions, and I think that kind of puts others in perspective.
And I do think that I would say, just in terms of, I'm not sure about other areas, but I know in the Atlantic region, the governments have been supporting students to take that, like there used to be a fee to take the continuing care assistant program or personal care worker program, and those are now free because of the shortage in this region anyway, to get people to take those courses. So I think that's an important piece. I also think, and it's the reason why I'm an adjunct prof at Faculty of Medicine at Dal, is that we need more inclusion of training around interacting with older people and recognizing the value of talking to their caregiver, as well as talking to the older person or the person that they're the physician for. So there's all kinds of ways where it could be enhanced. Absolutely.
So that's putting it across the university level, training of medical personnel or training of psychiatric work and so on, that seniors needs and what seniors, the relationship with seniors is a really important one. Yeah.
The amount of
Go ahead,
amount of professionals taking their geriatric specialty is very low, and the number of geriatricians is, so behind the demand. There's a lot of mixed messages going from the provincial and federal governments to the private and community colleges who are training the PSWs. We're bringing immigration in. We need you to train them. We're canceling immigration programs, but there's still pathways for PSWs. Lots of mixed messages coming out there.
I have to say, it's also about ageism, because if you're a nurse in long-term care, you're not as respected as you are a nurse in emergency. And so like it's not just one piece. It's like we have to look at it societally, in my perspective, because there's that hidden ageism there, that if you're working with older people, well, you must not have been able to make it with pediatrics or something. I have no idea.
Yeah.
But
yeah, that's
I think that also feeds into some of the workforce shortages in home and community-based care, because the wages, the shifts, the respect is better the more acute care the setting, right? So hospitals, acute care, long-term care, and home care has the least attractive in terms of pay and stability for people, although it's often the most meaningful for people. But that's why partly you see the shortage in home care staff, because they're drawn to the conditions that are understandably going to be more stable.
And it's the most intimate because they're in your home and you've seen them on a regular basis.
Yeah. We've got about 5 more minutes. Is there one more question, Audrey?
Yeah, well, here's a question. I'm going to read it, and because I want to interpret it properly, it's come up. With construction of long-term cares being beds being stalled because of the cost that's happened in BC lately, in the last couple of days, what logic or argument can be used to agree that the costs are not going to get cheaper as the demand increases, and to use those funds now to increase the coordination and all those pieces that we've heard today of aging in place or aging at home? How can we lobby to get that piece in place? And I don't know whether it's the same across the country, but here in BC, they're not building any more long-term care, and there's a great demand for them. We know there are people in long-term care that don't need to be there. That just was the place to move them because we didn't have aging at home. Anthony, I saw your hand up.
In Ontario and BC, the promises were sort of political, and meeting the promises and demand are two different things. In Ontario, 56,000 new beds were promised, and they're at about 7,000, and they're supposed to be built by the end of this year. So big lag in the promise to the delivery, and they are building these large apartment block style homes, not what the best practices tell you that is best for both the resident and for the caregivers themselves working in those environments.
And there's another question that relates to that too, that gives the example of the in younger people, where they're putting people, where people with disabilities are living in small care homes, it's a much more successful piece. And so how does that translate into
Well,
supporting seniors? That's a
that
question.
happened in large part because of the disability rights movement and people saying we don't want to be in institutions and getting a look at the insides of institutions, which for people with disabilities were really warehousing people.
Yeah.
And I don't, not all long-term care, some long-term care homes are wonderful, right?
Yeah.
But as we saw during COVID, when it's not working and we had to send the army in, when it's not working, it is really not working and people are not doing well. So it does take that pushback from the public to say, I don't want my mom, my husband, my partner to be in those sorts of conditions. I mean, other countries have learned how to have these smaller complex care providers. Not, we're not saying that hospital at home is the answer for everybody either. Not everybody can do that or wants to, and that's okay. But I think the kinds of long-term care that have been favored lately are cheaper to build, very congregate settings, and aren't necessarily, as Anthony says, taking in the best practice learnings for either the workers, the families, or the residents. There's one other model I want to shout out, which is called Nursing Homes Without Walls, which
Yeah.
also originated in the Maritimes. There's a lot to learn from the Maritimes, but you guys were the first part of the country to be super aged. So
Yeah.
and now
We,
there's a reason we're learning for you. So now it's spreading across Canada. It's coming
yeah.
to Ontario and Alberta, which is taking these long-term care spaces and assisted living spaces and really bringing the leveraging what they have in the built environment, whether it's a foot care program or a specialized bath, and allowing people who are accessing home care into those facilities,
Yeah.
and providing lots of other social supports with it as well. So that's another thing that we can be looking at in
Mhm.
terms of improving
Yeah.
people's capacity to have someone age at home, because
Yeah.
it's
And
not
I
easy.
think there in some of the questions, people were talking about social isolation. Like, is that like if I can't get out, is this the right way to be doing this? And I
Mhm.
think,
Mm.
just a shout out to some of the long-term care facilities. And I would invite people to look at both Nova Scotia and Alberta's. They have facility requirements, policies about the built environment when they're building new buildings. And they're very they attempt to be as home-like as possible. So I think that's a really important piece that some governments have tried this, but I also think not all long-term care homes, I call them homes, are negative. There's a lot of value. It's the same with caregiving, as you would know, Liv. Like there's a lot of challenges and burdens, but there's also a lot of joy and positive aspects of caregiving as well, right? So yeah,
100%. It's
yeah,
all about enabling conditions, right? If
exactly.
you
Yeah,
build a long-term care support that is responsive to everybody's needs, then it can be a wonderful thing.
And that's a great place to wrap up. It can
okay.
be a wonderful thing if we do things well.
Yeah.
So, Audrey, would you like to say the thank yous and give us a conclusion?
I can say the thank yous. I'm not sure I can conclude. My mother used to have a saying, "My brain is full. I can't answer you right now." So I have been in this area where we've been studying it and lobbying, advocating, and so on for many years, and we have learned so much over the years. And today I learned so much again and realized how much I still have to learn. Sharlene, your model, and that if there was one more question, that was the question I wanted to put in. People talked about how can we, even if our children are not in the community where we are, children and aging adults are not in the community where we are, how can we create communities that are intergenerational? Liv, I am so excited that we have this piece that is giving us so much background and information that very that we can go forward with this. It's a job that we've started. It's a program we've started, but we have a long way to go. Janice, I'm so glad you're in a secondary, post-secondary institution, because that's part of what we have been doing across the country. Linda Coles and I, as education people in post-secondary, we want to create more communication with that piece. Anthony, what a great partnership we have now, and it's very exciting because we need to move forward and let people know those statistics are absolutely incredible. There's somebody that isn't on.
Andre's
on, and so if
André lost his Wi-Fi and
saw that.
power at the hotel, so
but because this is being recorded, the overview of what the conditions are now, but were incredibly useful. The most exciting part for me is that he talked about the ways we can move forward, and we really need to move forward, and we need to keep creating the stories, because the stories will give us models of where we're going. And the people on today, I can see right now, there were 194 people on just shortly, a few minutes ago. We all will have those stories to create and move forward and be advocates. Thank you, Heather.
Thank you, everyone, for joining us today. Participants, speakers, it's been great. Thank you. And with that, I will invite you all to think about what we've talked about today and go forward. Join CARP. You have the opportunity, if you're a CFUW member, to join for free, and sign up for the Canadian Centre for Caregiving Excellence. Follow people like Sharlene and Janice. And we have a pet online. It's always good. So thanks very much, everybody. We'll see you on the other side.